Hello, everybody, and welcome to Supporting Strength and Strengthening Support, Minimizing Child Welfare Involvement for Substance-Exposed Newborns and Their Families. I'm Amanda Hopping-Wynn, Director here at the National Abandoned Infants Assistance Resource Center, located at the University of California at Berkeley. Today's webinar will be presented by Melissa Deane. Melissa began her social work career in 2004 as an investigator for New Hampshire's Division of Children, Youth, and Families, where she developed her passion for working with high-risk, underprivileged families in the prevention and reduction of child maltreatment. After completing her master's degree, Melissa specialized in medical social work in a variety of settings and institutions, including pediatric emergency medicine, inpatient pediatric behavioral health, maternal child health, and neonatal intensive care unit, and pediatric primary care. Melissa joined Boston Medical Center in 2012 as a child protection specialist for the child protection team and became the social work supervisor for the team in 2014. She joined the Respect Plus research project in 2013 as a consultant and has since expanded her role to provide clinical supervision to the project's family specialists. Melissa will be joined briefly by Paula Cardoza-Alves, the family specialist for Project Respect Plus. Paula is a trained substance abuse clinician and child development specialist who works with the pediatric care team to support mothers in treatment for opiate addiction and their children from birth through 12 months of age. Before we begin, I want to remind you that you can ask your questions via the chat feature in the lower left portion of your screen. We'll be answering questions at the end of the webinar, but please feel free to chat them in at any point. And now I'd like to turn it over to Melissa. Thank you so much for being here with us today, Melissa.
Thank you, Amanda. I'm really excited to be here and meet all of you. So again, my name is Melissa Deane. I'm a social worker at Boston Medical Center, and my role with this research project definitely expanded over time. So I've really gotten to kind of see all the lessons that we learned, as we learned them from the beginning and to where we are now. So this is a randomized controlled trial, and so we'll definitely be talking about the intervention part of the trial and Paula's role as the intervention, family specialist. But first, I would like to acknowledge the research participants for our study who were immensely helpful in kind of teaching us so much about their lives and their strength and resiliency, and also our research team members who are listed below. And then, we have no disclosures, no conflicts of interest. And our learning objectives for today, we want to describe the unique needs of opioid-dependent mothers and their infants. We want to identify benefits of implementing a multidisciplinary strengths-based approach for serving substance-exposed newborns and their families, and identify action items to create a supportive environment for opioid-dependent women and their infants. So just an overview of this project. So we called the project Respect Plus. It is based on the Strengthening Families Protective Factors, which include parental resilience, social connections, knowledge of parenting and child development, concrete support in times of need, and social and emotional competence. So we recruited these participants during their pregnancy from a specialized clinic. Our clinic was called the Respect Clinic. It is at Boston Medical Center, and the clinic specializes in both prenatal and postnatal care for women with substance abuse disorders. Our participants were part of this Respect Clinic and had substance use disorders regarding opiates or opioids that they had been using prior to seeking treatment. And so what they received in this program was both their prenatal care, but also support around their recovery. They could get a prescription for buprenorphine, or Subutex, and support around, getting connected to a methadone clinic if that was the medication that they also chose. So the support that was provided by the family specialist, who you'll meet in a moment, that began in the postpartum period and extended through the baby's 12th month birthday or 1 year birthday. And that included hospital and home visits, And well-child visits, meaning when the child went to their pediatrician, Paula Cardoso was there to support the mom and also provide anticipatory guidance kind of around all of what that might entail, shots, immunizations, things like that, and material resources for the families. So our goals for this research project were to decrease subsequent reports of maltreatment and to allow the parent to maintain custody. We unfortunately couldn't work with parents once they did lose custody of their children. Fortunately, this was a small subset of our research project. So by and large, the majority of our mothers maintained custody. How it works in Massachusetts is the law in Massachusetts states that a hospital is required to report to our Child Protective Service agency any child who's born substance exposed to an addictive drug at birth. And so we are mandated to report to them even when a baby is exposed to a prescribed drug such as methadone and the mom has been in recovery for years and years and years. So this is not a report for neglect. It's not a report for abuse. Substance-exposed newborn is its own category. And then our Department of Children and Families, who's our CPS agency here in Massachusetts, will make the choice of either screening that report out, because a parent, is in recovery and stable, or, choosing to screen it in for an investigation and possibly open up a case and provide more supportive services to the family as needed. So when we talk about decreasing subsequent reports, we acknowledge, okay, of course, the first report gets made regardless of, how successful the parents are, and then, we just want to make sure that, the family has all the supports that they need so that no reports for actual neglect or abuse are filed, and that the parents are able to maintain custody of their child. We want to support adherence to routine pediatric care. There's all sorts of reasons why this is a difficult thing for any parent to get to, particularly with a newborn baby. Those are a lot of appointments in the beginning. And if you have difficulty accessing public transportation, if you don't have a vehicle, if you live far from the city or far from your pediatrician's office, it may be difficult to go to. You may have multiple appointments. And so, this is just like one more appointment. And so if you're late to one, maybe you're going to be late to the pediatrician. And so we really wanted to kind of assist these families with these barriers. We wanted to improve parenting resilience and confidence, and I'm going to talk a lot about that later. But that's definitely an area where, we really needed to kind of help support and build confidence with these parents. Improve parenting knowledge and just kind of the expectations that they had of their kids, and just help them understand kind of the developmental milestones that were to come, and then to provide access to public benefits and resources, which are really tricky to navigate, even for the most resource person. So I did want to talk a little bit about opioid use in pregnancy. So, the American Academy of Pediatrics and also the American College of Obstetrics and Gynecology do recommend replacement of opioids or opiates that are used illicitly with prescribed methadone or buprenorphine, and this is determined to kind of be the most safe approach for babies, rather than prenatally, rather than have the mom either titrate completely off of her medication or substance that she's using, or just completely kind of stop cold turkey, and that can kind of be dangerous for the family. And also, the information that we have is just that 90%, this is from BART 2012, 90% of patients will return to illicit use subsequent to tapering off opioids. So just kind of acknowledging that, with Subutex and methadone, specifically in Massachusetts and likely elsewhere in the country, to be in those programs, you're getting your kind of recovery counseling, you're getting group therapy, so you are getting kind of that counseling. And these medications are reducing and eliminating opioid cravings. They're preventing symptoms of opioid withdrawal. They can, in the case of methadone, they can block the effect of other opioid medication that maybe is added on top of the prescribed medication. And it promotes the overall physical and emotional health of the mother, raising her quality of life. So when these moms are using illicit substances, they have to engage in illegal and dangerous activities to just, not be sick. And, they're constantly kind of, preventing themselves from feeling the terrible effects of withdrawal. And so it, is a significantly dangerous life. And so by getting this medication that's prescribed to them and, has been studied extensively, it's good for them, it's good for their babies, and, it kind of gets them to be ready to be parents. So most infants are born with neonatal abstinence syndrome when they've been exposed to either prescribed methadone or buprenorphine or illicit medications, and so this is something that we expect. This is a highly protocolized treatment for this syndrome, and I'll go a little bit into some of the symptoms of NAS, but I do want to acknowledge that these babies really usually are not experiencing these symptoms because we are treating them so quickly. But it's a constellation of neurologic and gastrointestinal symptoms. So it can look like hypertonia, which is increased muscle tone, so kind of really tense muscles, jitteriness, inconsolable crying, excessive sucking, poor feeding, diarrhea, vomiting, among other things. So, kind of imitating a little bit like what withdrawal looks like for an adult. And that can be really scary for moms because they know what it's like to feel withdrawal, and they're so scared that their babies are going to go through that experience. And, I'm going to talk a little bit about it more, but like the guilt and the self-blame that they feel, when they watch their children experience a modicum of that, those symptoms, is just tremendous. But, we're great at treating it, and so these babies really aren't experiencing those symptoms, if they are, not for very long. So another thing to think about with NAS is that these infants are likely going to be staying in the hospital for observation and treatment longer than the mom. So the mom stays, 72 hours vaginal delivery and, 5 days if it's a C-section delivery, and the baby may be staying up to 3 weeks for this treatment. So, if this is a mom that has other kids at home, has other obligations, and can't kind of be at her baby's bedside day in and day out, it's significantly impacting the attachment that, other mothers that aren't experiencing this would develop, that are able to kind of be with their babies, all day, every day, all night, every night, and really kind of learning about their baby's behavior. And, we know that mom being at bedside is actually really beneficial for, deterring the symptoms of NAS. And so, but, these are often parents of other children, and so sometimes it's just not an option. So we do acknowledge that this can have a significant impact on attachment. And the self-blame and guilt, I think that, becoming a new mom is a nerve-wracking experience for any mother, with substance abuse disorder or not. And, you're always thinking about, every little thing that happens with your newborn baby, and, if they're low birth weight or what it may be, and just every little thing that happened during your pregnancy, and, did I expose myself to free radicals, or, any, maybe I drank too much caffeine, all those things. And so, with these moms, they're feeling that, but compounded, and where mothers that aren't experiencing substance use disorder in their problem list history and their medical record, are being told by providers and their family members and their friends, like, oh, of course, like, you're a perfect parent, you did nothing wrong, none of this is your fault. That's not always the message that these families are hearing and these mothers are hearing, and sometimes they are actually getting their guilt and their shame compounded by the things that people are saying. And so, we do definitely acknowledge that, with this population of people. So, like I said, they definitely have unique needs that we need to be thinking about. The exciting thing is that becoming a parent, or realizing that you're becoming a parent, is a turning point in every person's life, and that it's, particularly a turning point in women that have been considering sobriety, maybe weren't successful in the past, but, are really going to try and commit now because, it's not just about them anymore. And, these moms also, they have a history of sometimes multiple substances that they're using. They may have a history of relapses, so kind of may feel, a history of kind of failures at this, and maybe that it's not going to work for me this time, it didn't work before, so kind of knowing that might be in the back of their heads. I want to talk a little bit about challenges in self-regulation related to the opioid replacement therapy. It's also can be called opiate agonist therapy, OAT, if that's a term you're more familiar with. But so, there's all sorts of aspects that go into what dosage you get and when your dosage needs to change. And when these moms do deliver their babies, their metabolism obviously changes when they are no longer pregnant. And so it can be a little bit of a challenge on the prescriber to kind of make sure that they're changing the dose when the patient needs it. I mean, we don't want to be too quick to lower the dose because we certainly don't want that mom experiencing any cravings. We don't want her experiencing any withdrawal at that critical period of time. But at the same time, we also want to be kind of mindful that we're not over-medicating. But it can happen, and there can be periods where the mom is a little bit more somnolent than usual. And, that's just something that we kind of have to give the mom some anticipatory guidance on so that she can kind of quickly recognize when, things aren't right and get that medication to the level that it needs to be. Also, just, almost all of our patients had, a current and usually a past history of trauma. And oftentimes that was why they were using the illicit substances in the beginning to kind of self-medicate. And also, had the history of kind of post-traumatic stress disorder, anxiety, depression. Most of our moms kind of had those dual diagnoses where they were self-medicating. Many of them had limited material resources for a variety of reasons. They may have started off with no socioeconomic status issues and then, kind of moved into poverty as their addiction really kind of took hold of their life and, may have been kind of cut off by family members who may have been able to help them financially because of kind of the behaviors that are sometimes associated with substance use disorders. And these families, have other needs too. So there may be family dynamic issues, with their own parents. We saw a lot of intimate partner violence or domestic violence, and that they may have other children to care for. So just kind of a multitude of psychosocial stressors going on for these moms. So next I want to talk a little bit about how we create a supportive environment for these women and their babies, which was kind of easier said than done and led to a lot of lessons learned because this wasn't obvious to us, from the get-go for sure. So, one of the more important things for us was just to kind of, look at all of the agencies and disciplines that the families are going to be interacting with during the time that they are, getting their prenatal care and, delivering their baby and then, outside in the world. And just kind of us realizing that there's a variety of levels of education around substance use disorder and opioid replacement therapy and NAS and just kind of all of that amongst the different medical staff that they're going to encounter. And that sometimes those experiences can be incredibly impactful. So, the difference between a provider that uses the term clean versus dirty urine or, the provider that says, your urine tested positive for benzodiazepines, instead of saying, your urine is dirty. And just how impactful that language can be and, staff members, referring to, a baby as a drug-addicted baby versus, a newborn baby that is diagnosed with neonatal abstinence syndrome. So just, there was a lot of different levels of education that the medical staff had about kind of the language and just kind of all the psychosocial issues that were going on for these families and how significant kind of their interventions with the family and their interactions with the family could be. And then, just realizing that the outside agencies really did need to kind of know a little bit more about our project and our program because that did lead to a little bit of confusion. Unfortunately, not all of our families went to Boston Medical Center for their pediatric care. And so Paul is going to talk a little bit about the geographical implications for that because, some of them got their pediatric care, hours away. But those clinics were not oftentimes very familiar with, all the medical diagnoses and just kind of the preferred nomenclature and all of that. And they also were really confused around our study. So I think that was another important lesson that we learned. The development of multidisciplinary crisis protocols kind of came up as the crises came up. So I got brought on as they realized that some of these moms were feeling suicidality. Usually it was passive suicidality, but were feeling suicidality, and there wasn't really a protocol for that. And so we developed one, and then making sure that we had a protocol for homicidality, which usually kind of looked like thoughts of harming the baby. So again, kind of more passive homicidality, not acute, but we need to have a plan for both those cases. And also, unfortunately, there are going to be times when we are concerned about neglect or abuse of the children that we're working with, and thinking about protective issues and how do we deal with that, because our family specialist wasn't necessarily a mandated reporter for the state, but we certainly had a vested interest in keeping children safe, and so just kind of we needed to kind of navigate that process, and it was a little bit dicey the first time that it happened, and I think it would have been helpful if we'd had that protocolized a little bit early on in the project. And just also to kind of consider the relationship between our intervention and Child Protective Services, because there's going to be a relationship, no matter whether or not we kind of wanted to acknowledge it in the beginning or not. What we're doing is kind of a level of Child Protective Services in itself, and so it was really helpful when the CPS folks were able to kind of hear about what our study was doing and how it was benefiting the clients that they were working with. So, regarding kind of the, lessons learned by the family specialist, Paula Cardoso is going to talk a little bit now about kind of the impact to the things that we didn't quite figure out early on, and how that affected her work with the families, but how we came around in the end. But Paula, I was first hoping that maybe you could talk a little bit more about what your role was with the study.
Hello, my name is Paula Cardozo Alves. I am the family specialist for the Respect Plus program. Thank you again for being here with us. I would like to share a little bit about the role with the Respect Plus and also the lessons learned during my intervention with the families. So my primary role as a family specialist is to provide care and case coordination for all moms who were randomized to this intervention. I meet moms shortly after they give birth while the baby is still inpatient at Boston Medical Center. My services it start from the birth until the baby turns 1 year old. My service includes well child visit, home visit, service referrals. I also connect mom to food pantries. I also do shelter referrals if they need it, and legal if there's any issues affecting the basic needs of this family. I also provide support and encourage mom to stay sober and to engage in the day treatment. The lessons that I learned during this intervention as a family specialist is that during this intervention, I had to really educate and help the medical staff about the opioid use, and also help advocate for mom to stay in the hospital when the baby is still in the hospital. I also had to form a relationship with the medical staff and also explain my role in the intervention that I will be providing to the families. I also had to support mom and encourage mom to stay overnight. And also I try to advocate for mom while in the hospital, make sure they get their meals and other support service they need while the baby's still in the hospital. And during the time that I meet with the mom in the hospital, I also had to identify the best way that we'll communicate and also be flexible. A lot of the time moms prefer text than phone calls. I also had to assist mom develop their support network, and I also had to be very flexible in terms of our meetings because these moms still engage in their methadone or suboxone treatment. So most of the time they have to go to the clinic on a daily basis and get their dose early in the morning. They also have to engage in a weekly counseling as a part of their treatment. And then also during my intervention, I had to be it was very hard to say hello and also very hard to say goodbye to these moms. My involvement is from the birth to the 12 months, and it's very hard to form a relationship with this population during this time. Most of the time it takes us about 6 months to build a relationship, And by the time I have to also start introduce the goodbye and then also a plan for the discharge. Because of this population is very difficult sometimes, I have to create different ways to engage them in the services. So before they discharge from the hospital, I usually have a plan so we can go over and have services that I need to connect them into the community.
Thank you, Paula. So Paula's role really was kind of the heart of our study, and definitely the work lent itself to secondary trauma, vicarious traumatization. She was really kind of bearing witness to a lot of the trauma that was kind of oftentimes ongoing for these families, and kind of riding the roller coaster of their lives with them. And so the work really, we realized it really couldn't be underestimated, and the amount of support that we needed to provide to our family specialists, really needed to kind of reflect that, and I don't think did initially. So we expanded the support to kind of look like, in-house and community training. So when available, in-house and community trainings, and not just on kind of substance use disorders or recovery, but, kind of on all aspects of parenting and trauma, mental health issues, things like that. So whenever there was a training available, we really wanted to make sure that Paula was able to go. Weekly case conferencing was really important to kind of talk about issues that came up, protocols that we needed to kind of come up with as issues came up. We did have a weekly multidisciplinary case review, which kind of unfolded over time, and that was immensely helpful, just kind of having all these different disciplines with their various levels of expertise on different areas, be able to kind of hear Paula's cases and, in a de-identified way, of course, but to be able to hear the issues and weigh in and kind of help advocate for these families and help support Paula in the wonderful work that she was able to do. And we also made sure that Paula was able to get weekly individual supervision with a mental health clinician so that she could kind of be looking at how she was managing all of kind of the information that was coming her way and how she was feeling about it. We didn't initially have a legal consultant, but that role became invaluable because almost all of our families were experiencing significant housing issues, and the relationship that we have in Boston, we have this program called Medical Legal Partnership, which works with Boston Medical Center, and it's a pro bono service to our patients, and they do a lot of work around housing, landlords that maybe aren't doing what they need to be doing, government agencies that maybe are eliminating people from certain resources that maybe they actually are entitled to, domestic violence issues such as restraining orders, things like that. So that consultation ended up being incredibly helpful. And even getting people their food stamps when their food stamps were inexplicably shut off. So that became something that we realized was important kind of as we went. And then another thing that we developed kind of, again, as we went was that there needed to be a social worker and a physician that were available kind of as needed 24/7. So, in addition to Paula's role as a family specialist, we also had research assistants that were providing, baseline questionnaires and, questionnaire again at 6 months. And so things were coming up. I mean, the questionnaires were pretty intimate, and so things were definitely coming up, and there would be times that they really needed that backup. And so that was kind of developed, as we went. So I'll talk a little bit about with the interventions and things that we realized. I think the most important was just kind of recognizing and celebrating the universality of the parenting experience. And what I mean by that is this is a really exciting time. You walk into maternity and it's the happiest place in the hospital for certain. And this is a really exciting moment in this mom's life, and her life is never going to be the same. And really being able to kind of walk into that room with a positive attitude, because sometimes you walk into the room of a mom that has a substance use history, and I think that there sometimes is a hesitancy to be celebratory, and Paula never had that hesitancy, and I think that was really important because it kind of allowed the parents permission to celebrate something that's really, truly wonderful. And they did do a good job at keeping their baby healthy, by maintaining in their treatment and being on opioid replacement therapy, and they are good moms. And this is exciting. This is an amazing moment, and so really kind of making it about that instead of necessarily other things, and kind of in line with that their opioid use history, while it's a significant impact in their life, it's one aspect of who they are and one aspect of their family dynamic, and really recognizing that these women are so many things before they're a person with substance use disorder. And so I think that was one way that Paula was able to kind of get them to eventually let their guard down with her when there were so many reasons why maybe they shouldn't, kind of trust different providers, but they really felt like she was treating them like a human, which, kind of goes without saying, but sometimes it's a little bit harder to do, than you might think. So, Paula touched on this, with the earning families trust, it took 6 months, and that wasn't something that we thought would be the case when we kind of first started this intervention. I think we're anticipating that it would be, like 6 weeks. So, but what we really weren't understanding is all the barriers to why these moms weren't really willing to open up to us in the beginning. I think that there's, confusion around, are you a social worker, and kind of social worker being, synonymous with the people that take my baby away from me. And so kind of making sure that Paula's role is really separated from the hospital social worker, who, again, is not the person that takes anyone's baby away from them, but the social worker is kind of known as the person that might file the report with CPS. And so kind of really taking Paula away from that role and really being, no, this is just your support. This is just for you. And then, these women have had experiences where they've opened up and they've told, intimate details of their history and their traumas to multiple people in their lives, multiple counselors. And, I think the nature of the beast is that the turnover is really high in this work, in this industry. And, so just as they start to get to know one person, that person leaves. And, kind of actually it was true for us too, because, right around the 6 month, the 6 month mark, when Paula kind of really established trust with the family, they really kind of saw that she was going to follow through on what she said she was going to do, and they realized that she really did have their best interest at heart. It was like right around the time that she had to think about terminating. So for good reason, these parents take a while to kind of open up. And then just thinking about the fact that many of these moms weren't really mothered themselves, and may not have had relationships at all with one or both of their parents, and may have grown up in the custody of the state themselves. So, how difficult that might be for someone, to kind of just be a great parent when they've never really actually seen what that is. And so how important kind of supporting that parent with that was. And I don't know that we had thought about that when we initially developed our intervention. And one lesson that was learned pretty quickly was that it was really important to kind of take the cues from the parent and make the goals that the parent wanted. And, you can't push your agenda. You really have to kind of meet them where they're at. And Paula was, amazing at doing that. And I think that also really helped to kind of encourage the parents to open up and realize that, this isn't necessarily agenda-driven. This is, really to try and support you and support your baby in your goals, which really are going to be our goals, which is to kind of parent your baby and allow them to kind of meet their potential, which is what we really all want.
So I'm going to talk again about more lessons that we learned during our intervention. So the other lessons that I learned during this intervention is that providing parenting intervention is extremely difficult for some moms that don't have a stable home. Unfortunately, with the moms that I work with, a lot of these moms, they don't have a stable housing. It's either they placed in a shelter, or they stay with a family friends, or they working towards a different housing program. I had a specific mom that she was placed in a shelter, and then she stayed for a little bit, and then she started to struggle with the shelter rules, didn't want to follow the curfew, so she decided she would leave the shelter without give them appropriate notice. So unfortunately, Massachusetts law, once you leave the shelter without appropriate notice, you will lose all your benefits. What all your housing benefits, and you also not able to apply for another housing benefit for another year. So she had to wait another year to start again the process. So it took her a little bit time, and then it was very hard to provide a good intervention because of the housing situation with this particular mom. And then the other lesson that I learned is that 12 months intervention is not enough for this population. Like I said in the beginning, is that it takes us about 6 months to build a relationship, to start and get to more information about their past history, their current history, and also trying to connect them with the service that they need. So I learned that 12 months was not enough to provide a good intervention. Also, the lesson that we learned is that our referral comes from different places throughout Massachusetts. It was not only for Boston family, it was for all the Massachusetts moms. So we had a big number of different cities that we was working with. And also, the other lesson that I learned is that I had to be very flexible and also very and advocate for my moms during the well-child visit. During the well-child visit, especially the 6 months, the 9 months, when the babies get immunizations shots, it was very hard for this mom to see their babies get the shots. It was very hard for them to see the needles, and a lot of the times we would talk after the visit, and then they identified the needles as the triggers for them. And then this was a very hard thing to watch. So I had to be there, support them, and advocate from the also advocate hospital staff why this mom has such a fear. It's not easy for them to bring their babies for immunization shots.
So just for future intervention studies, just what Paula was saying, starting the intervention early in pregnancy, I think that could be really beneficial to start once they first enter prenatal care, which is oftentimes around 3 months, so that you do have that established relationship, for when the baby's born, which I think could be really helpful. Kind of figuring out a protocol or kind of working into your intervention, how to engage with the parents, or the partners of the mothers, and the fathers of the babies. Incorporating community-based intervention in addition to home-based intervention. So, these moms have so many appointments that they have to go to, and so many places where they really could benefit from that level of advocacy, when they go to, try and renew their food stamps, when they go to WIC, when they, Women, Infants, and Children, when they go to, the methadone clinic. There's various different kind of appointments that I think, if the patient, preferred it, I think it would have been helpful if we were able to accommodate, attending those appointments with them and advocating for them. Being able to really have a manner of keeping track of the text messaging that's going back and forth between the parents. That was definitely the preferred mode of communication across the board, regardless of the age of our parents. And so, to really be able to look at that information in a qualitative way and analyze it, for coding and things like that. We didn't really work that into our study because we didn't really know how significantly the text feature would be used. And then just kind of establish relationships with the community-based advocacy agencies prior to the intervention. So just kind of making sure that you have a lay of the land of what's out there in the community so that you're, really kind of, strengthening what's already out there, but filling in the gaps. And so I think that would have been beneficial as well. Thank you so much for all of your attention, and we're ready for questions if you have any.
Great, thank you. We do have one question. Did hospital staff or child welfare have a written plan of safe care for after hospital discharge? This is not to be confused with a safety plan.
So the social in our hospital, kind of how it works is the social worker on the pediatric floor where the babies are. That social worker is kind of responsible for the social risk factors of that discharge. I hope. Let me know if I don't answer this in the way that you want, but so basically that social worker, who oftentimes did get confused with Paula, she would be doing a full psychosocial assessment with the family and be talking to DCF it's DCF in our state, CPS services, and just kind of finding out, okay, what are all the protective issues for this family? What are all the mitigating factors that, are maybe kind of diminishing those protective factors? How much time does this mom have in recovery? How stable is she? What are her supports? So they're really kind of looking at this person in their environment and kind of what does that environment look like? How can we kind of stabilize that environment more? And so, that social worker is really kind of owning that social risk, if you will, and, working with, in Massachusetts it's called DCF, so working with DCF, and Paula, you can kind of jump in to kind of finish.
Yes. I just wanted to add one more point is that with the Boston Medical Center, we don't have like a specific protocol, but a lot of the times, like Melissa said, like we make sure all the basic needs are there. And I had a family that at the time that it discharged, she was homeless. She didn't have a place to go. So when that happens, usually it gets a little bit difficult because the hospital, the safety is first, so we have to make sure that the baby has a home to go to. So in that case, mom lost custody because of the housing issue, so the baby went DCF for foster care until mom can provide a stable home for this baby. So that also happens sometimes. Is that clear?
Did that answer the question?
Annabelle, if they did not answer the question, please feel free to chat in any follow-up questions. She says, yes, that did answer it.
Okay,
thank you.
Next question is, have you ever considered using a public health nurse in this role?
I don't think, so I haven't heard it discussed, but now that you mention it, that seems amazing.
Just to add, this is Paul again. Sometimes our family get a visiting nurse, but it's just short of period of time when they go home. If it's like to monitor the weight, the feeding, so a lot of the times our families get that when they discharge home.
And, one other thing to just kind of add, so the supportive staff that we do have on our team, our, research assistants and I think even our lawyer, both had masters in public health. It's not the same thing as a public health nurse for sure, but I do think that kind of that public health background and just kind of way of thinking is really beneficial to a study like this. But I like the idea.
Great. Did you work with fathers or partners at all in this project?
I'll answer that question. Again, our goal is to work with mom and dad, but a lot of this time, in this situation, a lot of the time, dads were not present for various different reasons. A lot of the time, the dad was incarcerated. A lot of the time, dad's still in the treatment, like a residential program, so I couldn't work with dad. And most of the time, it's just mom. But I had a few dads that were involved, and it was great. They were very positive, very encouraged. So I had a situation that I had dads, but I didn't have a lot of fathers involved, unfortunately. And I think this is something for the lesson learned also for the future study. I think we should engage more fathers.
But if they were present, they could be involved in the study?
Yes, if they live home with mom, if they live in the same house, yes, they can participate. But most of the contact was with mom in this study here. But if they were present, if they were safe, yes.
And I think, the only other thing that I would add is, engaging fathers is oftentimes not the same as engaging mothers. Like the ways that you would go at kind of engaging the two are sometimes different. And the feelings that dads have when they're watching their kids with NAS is a little bit different than the feelings that the moms have. And the dads, just in my experience, and, not to kind of generalize half our population, but oftentimes, when I was in the role as a social worker of supporting the dads, they really were looking for action items to do, like, I need to do something right now. And the things that they kind of needed were sometimes different than the moms. And I think why we included this, as a possible future study idea is just, making sure that you take into account like the father experience and the male experience, specifically in how you kind of write your intervention protocol, where we were just kind of engaging with the dads, but kind of in the same way that we were engaging with the moms, and I don't know if that was always beneficial.
Interesting. That makes a lot of sense. That there's a different emotional reaction, and so they need maybe more physical supports than the mom needs. Whereas mom might need more emotional support. Dad might want more instant.
Yeah, and like a good reference, like if you guys have time. So Michael Lane wrote a book called The Effect of the Infant on the Father, and it has a lot of interesting kind of ideas about how to kind of engage with fathers in a more specific way.
Great. Well, Melissa, thank you so much for speaking with us today. Paula, thank you as well. I'd also like to thank all of the participants on today's call. There is still time to register for other sessions in our Lessons Learned series happening today and tomorrow, brought to you by our AIA grantees. Please feel free to visit our website, aia.berkeley.edu, to register for other sessions. The PowerPoint slides from today were in the reminder email that went out this morning. They will also be attached to a post-session email that you'll get in just a little while. In that email, you'll also see a link for an evaluation. We would love to get your feedback on this session. So thank you all, Melissa, Paula, participants. We loved having you here today. Thank you.
Thank you.